Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. It's nice and cool over here. We've had some rain, so that's a wonderful blessing. It's my great pleasure to present this afternoon Dr. Tomé Honing, and she is a fertility specialist that hails from Windhoek. I'm sure it's not raining in Windhoek, but it's wonderful to have her over here, and she's going to be presenting on the silent burden of period pain, the silent burden of period pain. It gives me also great pleasure to have our sponsors this afternoon, that is Abbott, and they represented this afternoon by our two old friends from Abbott, Devon and Kamani. So we're going to be pressing straight on. And if I can just say at the beginning, Tomé has said that it's quite a long presentation, quite involved and intricate. So if we would please keep our questions to the end, because as we ask the questions, they'll probably pop up in the next slide. So Tomé, it's wonderful to have you. It's your first time with us, and we'd like to thank you on behalf of Abbott and the Cape Town, the Pelvic Floor Foundation of South Africa, for being with us. So without further waste of time, the silent burden of period pain. Tomé Honing of Windhoek.
Thank you, Dr. de Jong, for the kind introduction. So this lecture is really very much based on basics. I hope not to bore you with too much intricate detail, but I do find physiology really fascinating. So thank you, Abbott. Abbott did not buy my soul, but they did really motivate me to read more than 200 articles. Thank you, Abbott.
Wonderful, wonderful.
So the burden of disease. From this beautiful article, the prevalence really looks to be increasing as time goes on. Dysmenorrhea is the most common pathology that is faced by women of reproductive years, and this is regardless of race or age or economic status. The worldwide prevalence is somewhere between 50 and 95% of women of childbearing age, and right about almost 30% of these really experience severe pain. This study from SHUP from 2019, they looked at more than 32,000 women of childbearing age, and they focused their study on absenteeism versus presenteeism. Absenteeism meaning she took time off work or school, didn't go at all, and presenteeism meant she went, but not at full potential, so kind of loss of productivity. And obviously it's a bit difficult and maybe a bit soft around the edges to really equate this, but they came to a productivity loss of 33%, which resulted in a mean of almost 9 days of total loss and productivity per year due to presenteeism. And in this study, the girls or the ladies under 21 were more likely to report absenteeism rather than presenteeism. In a similar study in Australia, they looked at fewer respondents, 1,200, but almost 77% of these reported having bothersome menstrual symptoms, and almost half of them reported some form of missed days of work or study because of their symptoms. Again, the young ones, in this case under 24, were more likely to report time away. But if they tried to equate this to Australian dollar, it came to 14.2 billion per year that was lost, which really just means that this needs our attention. I think what really stood out for me, some of the, they added in the article some of the words of the ladies. So this one said, if I'd known what I was experiencing wasn't normal, or if I'd had people give me a little bit of a better education around what to expect, I would have gotten to this place sooner. And I think even though, thankfully, with the internet and availability of data and access to data nowadays, you don't have to go to the library anymore. I think it is much less of a taboo subject. But many mothers still struggle to tell their daughters about periods and dysmenorrhea, etc. And the mom often also had severe pain or some form of pain. And she then tells her daughter, this is normal, you know, Eve ate the apple, this is life. So I think another thing that really stood out for me is a lot of these women in the Australian one didn't think their problem was bad enough. So 44% of them had this problem and they didn't even speak to their GP about it. So they just thought, again, this was life. So really this warrants our attention and we can make a difference. So if we look at the etiology of dysmenorrhea, primary dysmenorrhea is thought to occur in the absence of an organic cause. Let's just quickly see whether I can get this away. Yes. And secondary dysmenorrhea is then associated with underlying pathology. I thought this is really beautiful especially for people who don't do laparoscopies often. But if you look at picture 1, I don't know whether you can see my pointer, but picture 1 there.
You can, yes, you can see your pointer.
Excellent.
Yeah.
Superficial peritoneal endometriosis, and there on the pic you see it there. 2 is then deep infiltrating endometriosis, often uterosacral or rectovaginal endometriosis, and then 3, the chocolate cyst endometrioma, and then extrapelvic endometriosis. Here they depicted umbilical endometriosis. We seem to lately see a lot of pleural or thoracic cavity endometriosis in or in Namibia, but especially from the north. It seems like this is, I don't know whether there's just more awareness, but I see between 5 and 7 patients easily in half a year with thoracic endometriosis. So if we look at other conditions which overlap then with endometriosis, adenomyosis would also have cyclical pain, non-menstrual pelvic pain, and then deep dyspareunia. So would myoma or uterine fibroids. Primary dysmenorrhea would only be cyclical. Cervical stenosis, initially cyclical, maybe then non-cyclical as well. Malarian abnormalities, thankfully quite rare, but similar to cervical stenosis. Pelvic floor myofascial pain, we would very quickly refer to you guys, but then that would be cyclical, non-cyclical, and then deep dyspareunia. Irritable bowel, which is often seen in combination with dysmenorrhea, would be mostly non-menstrual, often associated with stress or eating things, etc. as well. Interstitial cystitis, not cyclical, and pelvic venous disorder, often not cyclical in its pain pattern. So if we look at endometriosis, the prevalence differs a lot depending on what criteria is used for diagnosis. So initially, there was more of an emphasis towards surgical diagnosis only, meaning suspect endometriosis but can only be confirmed with laparoscopy or laparotomy. Then an ultrasound, definitely with an endometrioma, there's quite suggestive pictures, different from, for example, hemorrhagic corpus luteum. But if we look at the overall estimation, it's around about 18%, maybe between 16 and 20% of women of reproductive years worldwide. But it seems, for example, in people with dysmenorrhea and infertility, almost 60% of these patients have some form of endometriosis. The endometriosis symptoms are often a bit wider only than period pain. So we've got chronic pelvic pain, dyspareunia, constipation, diarrhea, dyschezia, and then adenomyosis, we'll come to that, sometimes fatigue, depression, painful micturition. So it really encompasses a very wide spectrum then. So if we look at the sonar pictures, we would see nothing on transvaginal ultrasound, even for peritoneal deposits, maybe on MRI, but it's really not cost effective or practical to scan everyone with dysmenorrhea to see that they've got peritoneal deposits. And it still wouldn't necessarily change our management. Ovarian endometrioma, quite beautiful, matglas. Wat is matglas nou weer in Engels? In ieder geval matglas.
Hourglass.
Thank
What?
you.
Hourglass. What? Oh, ground glass.
Ground glass, thank you, ground glass.
Ground glass.
Ground glass, yeah. That's what it looks like at laparoscopy. And then DIE, you get an impression often that things are stuck, and occasionally there's a fluid collection. But on laparoscopy, you then know trouble is with you. If we look at the theories on the etiology, this seems to increase every few years. They find a new potential explanation. And the challenge is that none of these explain everything. So many of these explain part of our problem. But we all know the retrograde menstruation theory from Samsung, and then came Sulamic metaplasia. Stem cell theory does seem to make a bit of sense. Lymphovascular dissemination would make sense for how do we get endometriosis in the pleura or in the thoracic cavity. The invagination theory definitely makes sense with adenomyosis and some form of the chocolate cysts. And then genetics probably really play a role, either with genomic alterations with epigenetics. Maybe there is a genetic link where a mother is more likely to have a daughter that also has endometriosis. And then lately, there's also a lot of questions about iatrogenic spread, specifically with umbilical endometriosis after a laparoscopy. But I must say in Namibia, we see a lot of umbilical endometriosis in people who's never had a laparoscopy as well. So I don't think we have the full answer in that concern as well. I won't go into a lot of detail here. Very interesting articles. Some of them lose me a bit on the molecular levels. But we've got the ectopic implantation, and then we've got abnormal cell survival and invasion, almost like cancer cells, but they're not cancer cells. There's definitely some form of immune dysregulation, definitely some form of hyperestrogenism and progesterone resistance. We really feel this with fertility treatment. And then the tissue repair and fibrosis, where we call it this burnt out endometriosis, but sometimes they still have, even though they've got fibrosis, they still have this hyperalgesia where they really have severe pain. So if we look at endometriosis and or adenomyosis over a lady's lifespan, from pre-puberty, where she had no pain, up to post-menopause, where hopefully most of her pain will stop again, but some chronic pain might persist. Initially the dysmenorrhea, then the other vague things like diarrhea, dyschezia, constipation, hematuria, maybe chronic pelvic pain, depression, and mood disorders. Definitely the fertility thing, which could unfortunately take a big role, play a big role. Then in the 40s, early 50s, cardiovascular disease and hypertension and metabolic disease seem to be more closely associated with people with endometriosis. Exactly how is still questionable, but the same goes for autoimmune diseases. So it seems as if there is some link and some things which we don't understand completely yet. At the moment, still an association, no causality proven yet. I won't go into a lot of detail here as well. Very interesting article on all the different pain mechanisms and why people with endometriosis have such a lot of pain, from plastic pain, which has a lot of influences by the immune system, neuropathic pain with damage to the nerves, and then nociceptive pain. But the quick thing to look at here is they've got decreased pain inhibition coming from the central nervous down, and they've got pain amplification going up. So these people really, really suffer. So that was endometriosis. Now we go over to adenomyosis. So this means abnormal implantation of endometrial tissue with the presence of endometrial glands and stroma within the myometrium. So I often explain to patients it's like endometriosis of the muscle of your uterus. It is also often associated with an enlarging uterus, and it can really significantly reduce the lady's quality of life. They often present more with heavy bleeding, more than dysmenorrhea, but they also have chronic pelvic pain, dysmenorrhea, and infertility. Samsung was one of the first guys to also call clustered adenomyosis adenomyoma, kind of crossover between endometriosis and a fibroid. It was in 2010, a lot of attention was placed on adenomyosis because of palm coin, the approach to heavy menstrual bleeding, which we used to call menorrhagia. And it is the A of polyps, adenomyosis, leiomyoma, and malignancy for the structural causes of heavy menstrual bleeding. And like endometriosis, it is an estrogen responsive condition, which will also be the basis for our medical management, the way we see adenomyosis at the moment. So the true prevalence is still unknown because there's such a lot of debate between the pathologists of what really would equate to the diagnostic criteria. But in all women undergoing hysterectomy, it's estimated around about 10 to 60%. With the newer technologies, with ultrasound improvement and maybe MRIs, maybe 15 to 20% of all women, not even those undergoing hysterectomy. But it is often seen coexisting with fibroids and then with endometriosis. If hysterectomy was done for urogyne reasons, from retrospective studies, it seemed 20 to 30%. If the hysterectomy was done for heavy menstrual bleeding and pain, maybe 30 to 60%. But interestingly, 40% of women with endo also have adeno, and over 80% of women with endo and infertility will also have adenomyosis. So really a prominent thing. This I put in for our GP colleagues who don't work with ultrasounds and all of this all the time. But you get focal adenomyosis, then you get scattered ones. They often form lacunae. We've got diffuse, and then adenomyoma, which often looks like a soft fibroid or a degenerated fibroid. Hysterectomy specimens with lots of fibrosis there in the muscle. And then with fertility, we really struggle with these lacunae draining into the cavity. And on hysteroscopy, we see these pictures. If you open that up, there's literally chocolate draining out there. And then we've got this honeycombing of between the endometrium and the myometrium. Really not friendly environment for embryos to grow in, sadly. So clinically, we can't always pick adenomyosis up, but it's described as a soft, boggy uterus. It's often enlarged, mildly tender, but kind of non-specific. The Musa criteria, which was recently revised in 2022, I think really depicts it quite nicely with the direct features and the indirect features. Where I think now that we know what to look for, it's kind of much easier to see it. When I was still a registrar, we learned about the sun rays going past, but and we sometimes saw things but didn't know what we saw. So I think it's very nice now that we're more aware of it to actually see it. I think very interesting for people not doing obstetrics or fertility. There's a strong association with an increased risk of preeclampsia with people with adenomyosis, with quite a significant odds ratio of 4 to almost 8. Increased prevalence of small for gestational age, preterm labor, having a C-section, fetal malpresentations. And this seems to be more pronounced if it's on the posterior wall, because then you even get placenta accreta and friends, and placenta previa, which is not a fun thing. I will speak about the medical treatment in the rest of the talk, but just to quickly derail you to other surgical or non-medical options. So if a family is completed, one could consider uterine artery embolization. From a fertility viewpoint, we are quite against it because there are lots of complications. We've got recurrent implantation failure with IVF, lots of associations with miscarriages, and then from obstetric side, also postpartum hemorrhage. Endometrial ablation could hopefully decrease the bleeding a little bit, but the myometrial problem in the muscle would still persist, and they end up with a higher rate of hysterectomy in any case. On the other hand, hysterectomy from the beginning would also solve most of our adenomyosis problems because the muscle with all its problems will be removed. And in other countries, I'm not sure about South Africa, but we in Namibia don't have radio frequency ablation or high intensity focused ultrasounds, but they've also tried that. But if a family is not completed, then please refer to the fertility specialist for hysteroscopic resection or adenomyosis resection laparoscopically. Neither of them really rewarding surgery, but mostly we would focus on medical treatment. So segregated cycles where we would first harvest eggs and grow embryos, freeze it all, and then down-regulate the uterus and try and get control over the adenomyosis and then do a frozen embryo transfer. So fibroids, we know a lot of in Africa. So quite a few sonar pictures again. That looks like a type 2, almost 2 to 5, definitely touching the cavity there. On transverse view, you can see it's touching the cavity there. There's a little bit of distance on this photo, but with the great advancement of 3D ultrasounds, which are freely available now, you can really see that cavity is completely oppressed, or the fibroid is really in that cavity, submucosal fibroid, and that is strongly associated with really, really heavy bleeding and painful contractions. If we look at the FIO classification, I think the initial one was in 2010 or 2015, I don't remember exactly, but in any case, it was revised recently, no real major changes. But where we look at the location of the fibroids. So the submucosal type 1, 0, and 2 are really strongly associated with heavy bleeding and fertility. 2 to 5 starts from the inside to the outside, not a friendly fibroid either. And then 3, 4, and 5 could have some effect on fertility and bleeding and maybe pain. And 6 and 7 seem to be mostly causing pressure problems if of size. 8 is not your friend again, thankfully fairly rare. So surgical approach would mostly be laparoscopic myomectomy, if applicable, and then hysteroscopically, that is what a normal cavity looks like, and a few pictures of a submucosal fibroid that looks like a type 0, and then very patient, very gentle resection of that fibroid with a massive improvement in pain and bleeding symptoms. So a lot of questions about medical treatment of myoma. Everything that has been tried so far seems not to give us joy. Most fibroids are hormone sensitive. They could grow or not grow with progestogens and estrogen, be that her own production or the ones that we give her. So it seems as if GnRH analogs like Leukerin and Zoladex in most cases would cause degeneration and shrinking. But the problem with this is laparoscopic removal is then significantly more challenging because you lose your fibroid myometrial edge. So that tissue level is lost in most cases then. leading to possibly more myometrial damage than we would ideally have wanted. So if we look at the core principles in a practical sense, so if we look at the history, we ask about or hear about dysmenorrhea, heavy menstrual bleeding, think about fibroids and adenomyosis. We ask about desire for pregnancy, and if that's the case, then refer, because after myoma surgery, we still need at least 3 months before we would consider or advise pregnancy or IVF or whatever is applicable. On the examination, kind of non-specific. Maybe with the chocolate cyst, one could feel tender adnexa. Maybe with adenomyosis, a soft bulky uterus. Maybe uterosacral nodules could be palpated with biomanual. You could get an impression of stuck ovaries with endometriosis. But the truth is that biomanual examinations or pelvic examinations are really uncomfortable for most patients. And it's still not definitive. And we, in most cases, would still need extra imaging. So due to this, many of us are losing our skills because we do much less pelvic exams, which is maybe not a bad thing, but because we still do an ultrasound. So on ultrasound, we would see fibroids, we would see adenomyosis, we would see a chocolate cyst, and this would all influence our management. So in this talk, I will mainly talk about the first line, which is combined hormonal contraceptives, progestins only, levonorgestrel IUCDs, and then maybe other progestins. I would not spend a lot of time on GnRH analogs like Lucra, Zoladex, and then letrozole, which is the new kid on the block. Well, it's an old kid, but we're using it for new things. So all of the guidelines, or most of the guidelines, are moving away from needing a laparoscopy to diagnose endometriosis. So we treat it. If it sounds like that, we start treating it, and if it doesn't get better, then we look further. So the reasons to refer to a gynecologist would be if she desires pregnancy in the near future or currently, or if she's got fibroids, or if she declines or is not a candidate for one of our first-line hormonal suppression therapies, or if the pain persists despite our efforts, or if we suspect an ovarian chocolate cyst or DIE, or if adenomyosis is not responding, and then some of the other reasons which are slightly more complex. So our treatment aim is actually quite simple. It's get the right shoe for the right person. It's not a one size fits all. So there are so many options, and there are even more opinions and guidelines. I'll show you that article now if someone is interested. Very a nice one. But I like pictures and I like understanding things. So in this pathophysiology and understanding our targets, if we look at the hypothalamus secreting GnRH to the pituitary gland, this is where our Zoladex and Lucrin would work. And it would stop that, and then downstream there would be less estrogen, and we would have hyperestrogenic state, and there would be regression of adenomyotic and endometriotic implants. So if we look at COCs, combined hormonal contraceptives, maybe high-dose progestin sperms, we would block FSH and LH, which would also then decrease our ovarian estrogen and progestogen secretion. Then if we look at aromatase inhibitors, where androgens are changed into estrogens, we could block it there. Not great side effect profile. And then NSAIDs mostly on the COX inhibitors. And then progestins, which would cause decidualization and then atrophy of both the normal and the ectopic endometrial tissue, wherever it is. This is a very nice study. I think it was from 2024 or maybe 2025. But it has 8 of the major guidelines from France, Germany, Canada, ACOG, ASRM, NICE guidelines, ESHRE, on their guidelines for endometriosis. So most of the guidelines still mention NSAIDs as symptomatic treatment. So there's some discussion about maybe in an early teenager, if you give NSAIDs, maybe we could change the course of disease a little bit. But more proof is needed for that. And it seems like the evidence at the moment is rather weak. So the mechanism of action is relieving pain by inhibiting COX enzymes. Therefore, there would be less prostaglandins involved in the inflammation and pain. And it's not a long-term plan due to the possible side effects, gastric, renal, hypersensitivity, asthma, etc. The latest Cochrane actually showed a lack of high-quality evidence. And some studies even showed no difference in pain relief compared to placebo, which was slightly shocking. Again, use with caution with cardiac and renal disease, uncontrolled hypertension, peptic ulcer, etc. So the main first line would mostly be combined hormonal contraceptives. So most guidelines would recommend this as a first line, and it is often thought to be less effective than progestins only. But the good thing is it often has less side effects, specifically with skin and mood. In this meta-analysis by Brown, they showed that combined hormonal contraceptives definitely work better than placebo, which is good news. Now that we heard that about NSAIDs. So there are so many options. Oral pills with 20 to 30 micrograms of ethinyl estradiol, a whole lot of different progestogens, estradiol valerate and Dinogest with a fairly sometimes positive bleeding profile. We've got the weekly patch, the monthly ring. The mechanism of action is to suppress the ovarian hormone secretion, but via the negative feedback loop. But there would still be a little bit of estrogen. So it's not a complete, very low hyperestrogenic state. So there's still a little bit of that. Because of the progesterone component, there's also decidualization and atrophy of the endometrium, whether it's adenomyosis, endometriosis, or whatever. The side effects are fairly friendly, meaning less than 10% of headaches, mood changes, breast tenderness, less than 1% of decreased libido, and the nausea usually subsides, also less than 10%. So, and there's such a lot of options that one is likely to find something that suits the patient in front of you. Contraindications to specific
Tomé?
estrogen is... Oh, yes.
Sorry, Tomé, I know I said I wouldn't interrupt, but I've just got some people asking. We've had this debate before between Toby de Villiers and Dani Botha. Do you give the combined oral contraceptive pill continuously, as in tricycling, or do you have to give it monthly? So they do have periods, given that endometriosis is probably associated with periods and inflammation. How do you yourself give the oral contraceptive, and which preparation do you use?
So I think it's not a one size fits all. So I definitely lean towards tricycling, but that doesn't work for everyone. And if I have to tricycle, I'd probably go with Famodine, fairly friendly one. But again, that doesn't work for everyone. So with some people, Clara, for example, with a very light cycle, or even amenorrhea would be the answer. But because of the Dinogest component, some people really don't do well on that either. So I don't think it's a one size fits all. I think there is a study later in the a slide later in the presentation, yeah, which shows something about the benefit of tricycling versus cyclical use. But I think
Sorry, you did say,
there are so many opinions, and I think it's not a single one. So one should see what's best for the one in front of you. Yeah.
Thank you.
So, yeah, you're welcome. So, increased risk of blood clots with migraines with an aura, definitely a risk for strokes with oral estrogen specifically, and then hepatic disease. So we see quite a bit of hepatitis C with us, which I didn't notice as much before. So as a side note, oh, there we go. There's the tricycling, the continuous use, where we skip the placebo in the pill packet to achieve amenorrhea. So that has been shown to be superior to cyclical use with no difference in the safety profiles, but that can only be with monophasic. That is from Astani from 2025. There's the reference up there, yeah. So there are so many multiple formations of pills available. So the guidelines kind of lean towards the lowest dose of ethinyl estradiol. But the problem is the lower you go with the dose, the more breakthrough bleeding they have. And that's also where it's an individualized choice, you know. So I would tell them, let's see what's better. A little bit of breakthrough bleeding, but no pain. Or does the breakthrough bleeding bother you more, and you'd rather not have breakthrough bleeding, but maybe a little bit less pain control? But you know, but that's a very individualized experience, I think, with different patients. So Clara is said to have more amenorrhea or hypermenorrhea, light spotting, said to have minimal side effects, and also have little to no skin benefits on the other hand. So if a young teenager comes with acne and dysmenorrhea, Clara is probably not going to do it for the skin. And with the Dinogest component, which is an aldosterone derivative, I think in some people, receptor specific, that is where the mood things come from with Dinogest, similar to Vizan that we see. So this brings us to dihydrogesterone. So this one was actually developed in the 1950s already. I don't know why we dropped it for so long. In any case, it's a retroprogesterone. It's very closely resembling natural progesterone. It only has this slight bent configuration. And this allows more rigidity and the selectivity. So maybe just to give you guys a bit of background, we struggle with progesterone a lot in reproductive medicine. So progesterone is notoriously difficult to get into the human body because we break it down so quickly. And it's really not practical to expect a patient to do 4 times a day dosing. That's really not practical. So because of that challenge, the more synthetic progestogens were developed, like norethistone, acetate, etc., because it's so stable and the body doesn't break it down as easily. But the problem with that was that it also binds to a lot of other receptors, like androgens, glucocorticoids, mineralocorticoids, and the benefit of this retroprogesterone is that it's very progesterone receptor specific. So it has minimal or no other receptor binding, which then theoretically should lead to no weight gain, fluid retention, etc. And the other great thing is that there's higher oral bioavailability. So in reproductive medicine, we use a lot of vaginal progesterone in industrial doses, but I haven't found a woman who would prefer that. Most people would really rather drink it than have this white, uncomfortable discharge associated with vaginal dosing. So that really makes it a bit more friendly, and it is less synthetic compared to all the other progesterones that we have. And because of its specificity, we also have relative better effectiveness even at low doses, and then minimal side effects because of the specificity of this. Very slight bend there you see between B and C. So the mechanism of all progestogens, not only dydrogesterone, is that it induces dehydrogenation and then causes atrophy of the endometrial tissue. And it then also decreases estrogen-induced mitosis, and it suppresses cell proliferation. And interestingly, then also inhibits the inflammatory pathways with angiogenesis and neurogenesis. And this is really an interesting new thing with the TR theory, with the tissue injury and repair theories, where I don't think we completely understand the role of estrogen in this whole thing with inflammation yet. So this study from 2021, the Orchidea study, they used dydrogesterone 10 milligrams, 1 tablet, 2 or 3 times a day. And they tried now this either between day 5 and day 25 of a menstrual cycle or continuously. And the idea or the question was whether we would lose efficacy because she only uses it for a while now. But interesting, in these doses, definitely at 2 milligrams BD, that 2 and 3 milligrams, they had similar relief in pain with a very favorable effect and still improved quality of life. So they didn't really have a decreased efficacy with pain relief. So at 2 tablets a day, 20 milligrams, it also wouldn't even necessarily inhibit ovulation, but not in everyone because it does differ a little bit. So at 30 to 40 milligrams a day, most people would not ovulate. But the benefit is, again, it will also give luteal phase support. So in those people sort of trying to fall pregnant, this is really not a bad idea. We will not give this during IVF or during ovulation induction, for example. So there are so many regimes. Tang summarized it very nicely. I found this study really fascinating, where they had patients who had endometriosis surgery, and half of them, they only gave the surgery and saw who got pregnant. And the other half, they gave dydrogesterone in this cyclical day 5 to 25 one. And the ones on the dydrogesterone actually got pregnant in a shorter time, and there was a slightly higher rate of pregnancy in them. They also said that got an improved sexual function compared to, for example, combined hormonal contraceptives, with the increase in sex hormone binding globulin, which would decrease the free floating testosterone, decreasing the libido often. So specifically fertility-wise, we are always happy if they do not have a decreased libido. I won't go into a lot of detail here with the mechanisms of action, but it blocks inflammatory response. All progestogens do. It regulates the estrogen and progesterone secretion. Angiogenesis is decreased. Little bit of decrease of the extracellular matrix degradation, and then more apoptosis, which in this case is not a bad thing. Definitely decreases inflammation. Won't go into detail there now. When I spoke about the estrogen progesterone balance, there's definitely a lot of things there that we don't understand completely yet. So let's look at Dinogest. Dinogest was actually developed for endometriosis. Bazan is the handelsnaam. It is a 19-nortestrone derivative, and it can increase the progesterone beta expression in endometriosis lesions, and hopefully then overcome the progesterone resistance that we often see in endometriosis. It's very efficacious, and it's really got a high efficiency in decreasing pain and causing amenorrhea. Several RCTs have proven its efficacy for endometriosis, even including deep infiltrating endometriosis. It has been proven to decrease the size of endometriomas without decreasing the ovarian reserve, because that's our challenge with surgery. As soon as we go and operate on the endometriomas, definitely if you try and find that nodule, you kill a few thousand, if not million eggs. So 2 RCTs showed comparable efficacy of Vizan to Zoladex with a massive cost benefit. I mean, I know in South Africa, but Zoladex with us for a 28-day, the one that lasts 1 month, is around about 3,000 to 4,000 Namibian dollar, which is equitable to Rand. And the 3-month one, the 10.8, is 7,000 to 8,000. And the medical aid, you're not keen to pay for it. Whereas Vizan would mostly be paid for. But it comes at a price, not money-wise. So the side effects often lead to early discontinuation, even though many of the reviews were quite favorable. Even in the reviews, the patients would stop because they say the side effects weren't so bad, but they stopped using it. So in most of these, between 3 months and 5 years, the most common reason was actually abnormal uterine bleeding. Some people miraculously stopped for amenorrhea and then swelling. But there are also some other serious adverse events like decreased lumbar spine, mineral density, and depression. In practice, I definitely see the depression. It starts with a cup half empty, and then it slowly deteriorates. So there were a lot of debates regarding how long should we use Vizan alone. Initially, it was 18 months, then it was 6 months to a year again, then it was individualized. You can use it for 3 years. But in practice, I don't see a lot of people going beyond 2 years where they ask for a break. So then we talk about a Mirena. So in these meta-analyses, they only looked at Mirena, the bigger one, not in the Kylina, for specifically with regards to dysmenorrhea. So there was a significant reduction in dysmenorrhea. It's also very convenient. It lasts for 5 years. Side effects, breakthrough bleeding more than 10%, headaches and weight gain less than 10%. So also spontaneous expulsion and uterine perforation. A recent study in Australia tried Mirena on people with persistent pelvic pain, and their dysmenorrhea and their overall satisfaction with symptom control improved dramatically with as long as their periods decreased and until they had amenorrhea. So as a side note, the Mirena does not always consistently suppress ovulation. Therefore, we don't really recommend it for the management of ovarian endometriomas because they would still continue ovulating with the estrogen associated with that, etc. But it is approved for the treatment of heavy menstrual bleeding. In these people, amenorrhea of about 20% at 12 months, 40% at 24 months, whereas in the population before, where we don't have adenomyosis or heavy menstrual bleeding, there's almost 70% amenorrhea rate at 12 months. So unlike the systemic progestins, this one also doesn't have a negative effect on the lipid profile. So then we come to hydroxyprogesterone, the Depo-Provera, freely available, 150 milligrams every 3 months, even available in state, mostly significant reduction in pain. It's very cost effective, but comes to side effects, headaches, weight gain, gastrointestinal upset more than 10%, depression, decreased libido, less than 10%, breakthrough bleeding, less than 1%. Most importantly, the delay in return to fertility, something that a patient must be informed about. So the contraceptive effect and cycle irregularity often persists for up to 12 months. If I see a patient who had Depo-Provera in the last 9 months, I would not even look at bothering with ovulation induction and stuff like that. It leads to a lot of anxiety, etc. So we just ride the wave at least until 9 months after the last injection. A lot of studies about bone mineral density loss, specifically in adolescents, but it's often difficult to measure the exact value or extent of this. What does it really mean in clinical terms? Do they really have more fractures, or is it just compared to the population without Depo-Provera? So if we look at Implanon, 68 milligrams every 3 years, there's no studies comparing it to placebo for dysmenorrhea, but there are single studies that show that it does, especially if they have amenorrhea, that they will have a decrease in dysmenorrhea because they don't bleed. But there's, in this study, a 10% discontinuation due to unfavorable bleeding pattern. That's not what I've seen here. It's more like a freaking 80% discontinuation.
Yeah, I fully agree with you. Sorry to interrupt again, Tomé.
So I'm happy it's not only the Namibians.
No, it's not only the Namibians.
So, so as a woman myself, it really intrigued me. Why would a woman choose to have pain and not get something that could relieve the pain? And if I speak to my patients, it's mainly because of these three concerns. They're either afraid of getting fat, or they're afraid of getting cancer now or later, or they're afraid of not having babies once they want babies. So part of this problem is lack of awareness. She doesn't know about endo and adeno, etc. She didn't know it was abnormal. She doesn't have a baseline reference. You can only compare your own pain. You can't compare it to someone else's. And obviously, a lot of personality and other things would influence one's experience of pain. Fear of side effects, very, very real. And a patient really needs thorough and balanced information on the benefits and risks, specifically with her own makeup. Yeah. So I really think all of us can make a difference in at least informing and educating and telling people you don't need to suffer. So let's look at weight gain. Cochrane with combined hormonal contraceptives looked at 49 trials. They found no substantial weight gain in all of them. 2016, they looked at weight gain, Cochrane again, and progestins. And they said maybe depot does cause it. And they
Weight gain,
compared to, yeah,
definitely.
they
Maybe
compared
not. Definitely.
I compared it to copper. So this study was still very conservative. They said at 2 years, 2.7 kgs, at 3 years, 3.2 kgs. I, in practice, agree more with the second one, where there is definitely a change in body fat, even though their weight don't change, their body fat percentage will change. I think it's in the next slide, where it's closer to 7 to 12 kilograms. So if you, in this study, a more recent retrospective study, they again compare depot to copper IUCD, weight gain at 1 year versus 4 years, 3.5, versus 10 years, almost 7 kilograms, which is rather impressive. It's in a sad way. There are two studies that also reported on this change in body fat mass. So the actual weight is the same, but the body fat percentage changes with progesterone-only users versus women not using a hormonal method. Two of the studies looked at Mirena, and they said there wasn't such a big change, but not nothing. So watch this space, yeah. In this study, they looked at progestin-only contraceptives, and the mean weight gain over 6 to 12 months was less than 2 kg. A lot of the French studies also showed this. Some French ladies even lost weight on the Mirena. So, but we don't have a lot of French ladies in Namibia. Background, very interestingly, where's my reference here? This I really found, oh, there it is, Big CISA 2011 was the first one who reported that some weight gain might just be attributable to aging. So 1 to 2 kg per year, which is rather shocking. I used to see the grade 12s, and then they're all thin and small, and they go to varsity in South Africa, get fed very well, and come back with 10 kg. And I thought it's just because they don't eat their mother's food and they eat junk food, etc. And maybe some of that is still true, but maybe just with aging, there's also something. So in this study from 2017, they showed that weight gain during emerging adulthood between 18 and 25 is greater than any other period in the developmental life course. The greatest weight gain occurs in the early 20s, where incidentally she would also mostly be at varsity. And it's even worse in those who are already overweight. So the slightly plump girl are more likely to then gain 10 or 15 kilograms. But this doesn't mean everyone. So there's careful counseling, lifestyle choices. You can't eat everything that you see like when you were a teenager. And there's lots of pros and cons, and there are so many options. We don't have to all take Depo-Provera. So I think with all the blogs and whatever available nowadays, a lot of association is interpreted by patients as causation, and it's not the full truth. So I literally have a little scale in my practice with a picture of a scale where I say you win some and you lose some, and we try with whatever choice we have for the specific one to win more. So there's also cancer reduction. Ovarian cancer is significantly less, endometrial cancer is significantly less, colorectal cancer is significantly less with combined oral contraceptives. Lots of studies being done to prove that, but there is an increase in breast cancer. It's a minimal increase, 8 in 1,000, but it's not nothing during current use, and this lasts for 10 years. So it only disappears 10 years after she stopped using her hormonal contraceptives. Cervical cancer also increases.
Can I just interrupt? If you
Yeah.
look at a relative risk rate of 1.08, hell, that's very little. And although you might say it's significant, it is a very small, significant increase. Yeah.
Totally agree. With cervical cancer increase, this is only in people in the presence of HPV. So in people without HPV, this increased risk does not apply. So if we look at possibly breast cancer, hopefully not cervical cancer, and you gain all of this, a fear of cancer would not be enough reason, I think, to not get pain relief. So I won't go into that detail. Oh, my mens. So then future
in general terms, my rule of thumb is if it's got a relative risk of 2, then it's probably significant. If it's got a relative risk of 1.08, that's a hell of a small increase in relative risk.
Yes, I completely agree, yes. So future fertility is something that people are very afraid of. But if we look at this, we definitely need more data. But suppressing endometriosis and adenomyosis might actually be protective against future fertility, because if you just let adeno and endometriosis grow unabated, it might really be a stage 4 by the time she's trying to have kids. Whereas if you at least keep it at bay and suppress it to some extent, while improving the quality of life, you might actually preserve fertility. But we definitely need data to actually prove this. In this, other people are also, patients are also concerned about if she stops the pill, will she only fall pregnant next year or the year after? But in this systematic review by Giram in 2018, they looked at contraceptive use regardless of its duration and type. And they said it does not have a negative effect on the ability of the woman to conceive in general, compared to people who haven't used hormonal contraceptives at all. And it doesn't significantly delay fertility. So if a patient asks me a specific question, for example, the pill, I will show her the HBO axis and show her your hypothalamus and pituitary gland becomes lazy because you did the work for them for years or whatever. But in most people, it would wash out and wake up kind of after 3 months. In the exception, for example, of people with PCOS, so polycystic ovarian syndrome patients, in any case, didn't have a regular cycle beforehand. And it's not that she had no chance of falling pregnant, but if she has anovulatory cycles, she in any case had a smaller chance of falling pregnant. And this is worst if with the OFRO stories, they don't try to fall pregnant after they stop using the pill. So they say, no, they're going to use the condom or whatever and try for 3 months and then only going to try. A PCOS patient would specifically miss out because her FSH and specifically LH will be suppressed by the pill, and she has the biggest chance of falling pregnant the first month. So she completely wasted that if she didn't try. So one should look at pre-existing fertility things as well. I think the other interesting thing is young people use contraceptives because they think they're highly fertile. And then they blame the pill if they don't fall pregnant. But fertility was not necessarily proven before she started using the pill. So there's always that unknown as well. There are also other benefits like heavy menstrual bleeding that's reduced, people with irregular cycles starting to bleed in the middle of the exam and stuff like that, causing a lot of anxiety. With the pill, we can regulate the cycle. We can decrease acne with some of the ethinyl estradiol 20 to 30 microgram containing ones. And then the Germans specifically, all my German patients, they really like alternative medicine and natural stuff. So a few studies have been done on omega-3s, on physio, even studies on warm compresses and relieving pain, anti-inflammatory lifestyle and diet, acupuncture seems to maybe work a bit. Chinese herbs, if it doesn't kill you, it might work. And generally, I tell my patients, I'm not against trying all of that, but if you start using herbs, then just don't use it with my medicine because I don't always know what's in the herbs and it might potentiate each other or something like that. But I'm not against it completely, but none of these have been proven to really make a difference, because as doctors, we would all jump for it. If there's something that really made a difference and that is completely natural, most of us would go for that before we give synthetic things, yeah. So in summary, every one of us can make a difference. There's not a one size fits all. So it's individualized care to the one in front of us. Listen to what she needs, what's her specific story, inform her of the gaps in her understanding of the problem. And then please stop the suffering, alleviate the pain. Is that not why we all became doctors? Lots of references, which I can send to you if you'd like to.
Thank you so much. Tomé, it was a wonderful and especially practical and hands-on presentation. I'm going to ask Steve to thank you. Just one or two questions I've got. Steve, there's one question that I've done.
Thanks so much, Tomé. I'll just read this question. It's an interesting clinical question, and something that we all do face on a regular basis. And he asks, pain being subjective, is there anything that is a good predictor of pathology, especially in patients with primary dysmenorrhea, whose pain is usually regarded as normal until endometriosis is diagnosed very late? So it's really, where do you actually draw the line in terms of deciding it's sort of just a primary dysmenorrhea versus someone who's got endometriosis? Anything that you use that can help you before you actually go and diagnose it laparoscopically?
So not as a personal opinion yet, so let me start with the articles. So there's definitely a gentle movement away from this whole thing of primary dysmenorrhea, because you have to then actually do a laparoscopy and prove that there isn't pathology. And if we just say that we don't do laparoscopies, then what are we actually saying? So I think there's a gentle movement away from this and more of an emphasis on alleviate the pain. So if we don't see a chocolate cyst and we don't see a fibroid, then we manage the pain, we give whatever our first line treatment would then be, whether it's primary or secondary dysmenorrhea, alleviate the pain. In my own practice, I would really advise against, because ovaries tend to bleed when you look at them or something, I don't know. And then people tend to put the cautery to them and kill the eggs in a patient who's 22 and doesn't want babies yet. So I think if we can avoid surgery, that would still be the mainstay. I would only go in a young person who doesn't try and fall pregnant yet, go and see what's going on with a laparoscopy if all our treatments failed. You know, Vazan, we started with CHCs, we went to Vazan, we tried Tufaston, we tried everything, and nothing works. Then I would go and see, are we not missing something? Yeah. I think from urogynecology and this alternative approach to pelvic pain, not that I know a lot about it, but I do like that approach as well, where we look at other things, other causes of pain in the young ones, you know, where sometimes physio and all of that could maybe make a difference. Yeah.
Yeah, and I think that's a good idea. I know a lot of people like things like yoga, hot yoga, that kind of stuff, I think can work.
Yes, yes.
But I mean, I really like the approach that you take about not normalizing this. You know, I've been, I remember being a registrar and just on rounds where people would kind of normalize, sometimes dysmenorrhea, and it's, it's being off work once. I often listen to patients, and you hear them once, being off one or 2 days a month from work or school from pain. That doesn't make sense. Whereas over the years we have tended to normalize it, which is actually quite sad, really. But thanks for bringing attention to this condition.
Steve, did you hear recently this week the EFF, Julius Malema, said that they're thinking of introducing a new bill to allow 2 days of menstrual leave. It's called menstrual leave for women with dysmenorrhea. I don't know if anybody else picked that up, but I certainly did. And it's a very interesting concept. Have you heard about this? Isn't a Namibian thing. It's a South African thing, Tomé. But
I just thought maybe to fast on Orbizan would be cheaper to the economy.
Anyway, that's an aside. That's an aside.
Well, that's quite progressive from them, to be honest.
From EFF.
Honestly, yes.
Another question. Some people think that the incidence of breakthrough bleeding, you said, was less than 1% on Depo-Provera. And I must say, in my practice, when I use Depo, and I'm a bit against it at the moment because the association with meningiomas, but it was quite a common thing. Another question from Carmen Chiquire. Hi, Tomé. Thanks for the very informative, lovely talk. To clarify, are all cases of dysmenorrhea pathological, yes or no?
Wow.
No,
Okay,
nothing in
thank you.
life is 100%.
Okay, here's another anonymous says, it's a law in Zambia. That's this menstrual leave. Women get a day off every month for menstrual leave. So there you go, Zambia. Another
Wow.
question, Tomé. You mentioned in fibroids there's abnormal bleeding is a constant finding. Would you do, it says here, would you do endometrial sampling prior to any surgery, including hysterectomy, for a woman you've diagnosed fibroids in? Yes or no?
No.
Okay,
So
you wouldn't.
no, I think it's always debatable, and I think one should individualize. I think my counter question would be, are we trying to prove that she doesn't have ESS, endometrial stromal sarcoma, because she could still have a sarcoma, and we would miss it with hysteroscopy with sampling. So I do like to be informed, and I really don't like surprises. So if in doubt, it's probably better to get samples than not. But what are we trying to ascertain there in getting
Okay.
a sample? Yeah.
So you said that you could do endometrial sampling, but you often would miss a sarcoma even if you did hysteroscopy. Is that what you said?
Yes, because if it's in the muscle, we wouldn't see it with the hysteroscopy. So the
Okay.
intramural one, we wouldn't see with the hysteroscopy, or our sample would be clear, and she could still
Okay,
have
that's,
sarcoma, which we'll only find afterwards at histology.
that's interesting.
Yeah,
Steve,
to that point, Pete, to that point, for some of my laparoscopic myomectomies, I've started to do the odd frozen section in theatre. I don't know if that's something that is acceptable or what. I don't know if anyone's got an opinion about that, but prior to more sedating, you can obviously still miss it, but it is just one extra layer of protection against those cases. I don't know what you think of that, Pete or Tomé.
yeah, Tomé, what do you feel?
We can't do frozen cycles. I like the idea, but we can't do it.
You can't do
Namibia.
frozen sections in
No.
Pathologist
Namibia.
don't come to theatre. I was coming.
No,
I was
no.
happy to come, so we're very lucky. So, are there any other questions, Pete?
Steve, my question is this. Has everybody heard that we're doing FIGO in October, the first week of October, the 5th of October? There's FIGO. We've got over 500 South Africans that have registered. And Tomé, I don't know if you've heard about FIGO coming to Cape Town in October, but we would love to have you present. And it's going to be a wonderful, wonderful congress in Cape Town. Yeah, there was another question, and I'm just trying to erect my brains. It was for Chris. Chris, who do we have next week on the webinars? Is Chris still with us? Hello, Chris? He seems to have left us.
Mark
Okay,
Slack
never.
is with us. Mark Slack is with us.
Mark Slack. Okay. All right, we've got Mark Slack being our presenter next week. Now, you've all heard of Mark Slack. He was at Cape Town for many years. And he's talking, would you believe it, not on robots, because he makes his own robot in Cambridge, but he's talking on anemia. So that's going to be very exciting. His hobby is anemia. So, Steve, would you thank Tomé, please? And also thank, while we're about thanking also Devon and Carmeni on behalf of Abbott.
Yeah, well, thanks so much. It's indeed been wonderful having you, Tomé. I think you've highlighted a very important subject that we almost never talk about as gynecologists and as GPs and as other practitioners, but it's an important subject that needs attention, needs aggressive treatment, and I think it's making good progress here now. Yes, and we do thank Abbott for the support. Thanks again to Pete, and again, don't forget about FIGO. I think none of us will forget about it now ever. I think each one of those 500 registrations have been due to your efforts, Pete. So congratulations on that.
6 weeks time, Steve. 6 weeks time,
Yeah,
and I can see
forward to it.
you're a speaker there as well, Steve. I'm sure.
Yeah, absolutely. We're all looking forward to it. It's right next door, so can't miss it. But thanks so much, and
Thank you for having me.
seeing everybody next week. Yes, and hopefully coming down from
Namibia.
There will be a whole Namibian delegate.
Oh, excellent, great.
Tomé, it's been a wonderful talk. I just want to say, I'm hoping we can have you back on this platform again in the near future.
Thank you. Thank you very much. It was my privilege.
Over 200 people have registered and logged on, so it shows you how popular this talk has been. I'm sure Abbott is very happy for that as well.
Good. Okay, well, thank you very much. And it's time to log off. Thanks to everybody. We do appreciate your attendance. And we see you all next week with Mark Slack looking at importance of anemia. Thanks so much.
Thank you.
Thank
Good
you.
night and goodbye.
Thank you very much. Bye-bye.
Bye.